So I'm going to talk to you perfectly, I think, follow up on what Srinivas just talked to you and focus specifically on the utility of OCT imaging in complex and high-risk PCI. So the first question we have to ask ourselves, particularly in an economic situation such as we are in here, with the cost of the catheter is very high, and in fact the cost of a drug-eluting stent is lower, which patients actually benefit from imaging guidance? So this is a 46-year-old with hypertension, hyperlipidemia, and CCS class 2. He's direct stented with a 40/15 everolimus eluting stent, and this is the final result. Is this patient likely to benefit from intravascular imaging? Well, let's take a look. 2 contemporary trials, including our own, have shown that once you reach a minimal stent area of 6.8, your risk of target vessel failure starts to reach approximately 2.5%. So if you perfectly expand this 4.0 stent, you end up with a 12.6 millimeter squared area, far off to the right and unlikely to benefit. Even if you expand this to 70%, you end up with an 8.8 millimeter squared area, and as a result, this patient is unlikely to benefit from intravascular imaging. But Ajay has been intricately involved in the evolution of this concept of complex, high-risk, and indicated patients. And we've somewhat divided this simplistically or dumbed this down into high-risk clinical, high-risk angiographic, and high-risk hemodynamic features. And I think it's clear that these patients are undertreated, but it's also that these patients are the ones that benefit from imaging guidance and are suboptimally treated when they are treated. So the first question you have to ask yourself in these situations is, which patients are at risk? So if you look, this is a recent analysis from the Cardiovascular Research Foundation of 13,500 patients from contemporary drug-eluting stent studies, which shows which patients are most likely to end up with a target vessel failure. And you can see it's all of the things that we know on a day-to-day basis. When the patient comes into the lab, you know that diabetics and long lesions and bifurcations, severe calcifications, CTOs, ISRs, left main, and end-stage renal disease and CKD are more likely to lead to a target vessel failure. But here's the evidence. And actually, this concept of CHIP, unfortunately, is not dichotomized. It's overlapping. There are diabetic patients with bifurcations who also have a CTO, which actually creates a synergistic effect. But often we come up with the question, why do I need to image? The stents are cheaper. I have optimal results anyway. What's the purpose? Well, meta-analyses actually show very clearly that even in the most complex and higher risk patients, that there is a clear-cut benefit in terms of major adverse cardiovascular events, as well as target vessel failure and stent thrombosis and target lesion failure, etc., specifically for patients who are complex and high risk. So let's focus specifically on those categories that are high risk. This is a 36-year-old female with poorly controlled diabetes who's on an insulin pump. She's morbidly obese, turned down for cardiac surgery because of her morbid obesity. And I asked myself, in real life, this is a real case, and one of my closest colleagues is working in the room next to me, what size and length stent would you place in the LAD? And my original plan was actually to put a 2.75 millimeter distally and a 3.5 millimeter stent proximally, and I toyed with the idea of using intravascular imaging, but it was quite late at night, and my colleague who was in the other room said to me, it wasn't Ajay, by the way. It said, you know, maybe let's just get in and out. Let's just get this case done. So here you can see that in the end I ended up performing OCT, and where I'd planned to put a 275 distally, it turns out the artery is almost 4 millimeters. And as a result, I would have been grossly undersizing my stent. And at the proximal reference, you can actually see that this artery is almost 5 millimeters. And this is the major benefit of intravascular imaging. It allows you to put a tailor-made suit into the artery instead of a suit off the rack. But there's more to this. We not only were sizing this wrong, but now we learn with precision PCI using OCT that the length from normal to normal is 49.2 millimeters. So I know I need a distal vessel is 3.8 millimeters and the proximal vessel is 5.5 and the length is 49.2. Which stents should I choose, and can OCT help me? Well, let's take a look. Using this very simple technique by turning on this thing called bifurcation mode, you can actually ask the OCT to identify all branches that are more than 1.5 millimeters in an automated method. What does that allow you to do? It allows you to determine exactly where these branch points are and therefore determine that a 22 millimeter stent will lead to double jailing of a side branch, as will a 38 millimeter stent. Instead, what you can do is perform a tailored therapy and identify that a 33 millimeter stent distally will land both distally and proximally into a completely normal segment of artery, and an 18 millimeter stent proximally will also land from normal to normal. Critically, this also takes into account the dynamic range of each of the stents, because a 3.5 millimeter stent cannot be taken up to 5.5 millimeters. And actually these stents have dynamic ranges which should not be overcome, after which the polymer and drug become unreliable. What about non-ST elevation ACS? Another case where one of my colleagues was on the telephone with the surgeons referring this patient for CABG following the identification of this left main lesion, where we actually convinced them to say, well, let's perform an intravascular imaging because of a hazy appearance in the ramus. So, quite interestingly, you'll note that the minimal lumen area from a healed plaque rupture in the left main coronary is actually 9 millimeters squared, completely stable and unnecessary of treatment. Certainly not with CABG, and in fact the plaque rupture is a relatively straightforward lesion in the ramus intermedius, which was treated with direct stenting. What about bifurcations? How can intravascular imaging help with bifurcations? This is a Medina 111 and planned treatment with a 2-stent strategy. And you can see that following intravascular imaging, even with intravascular imaging guidance, but with an angiographic recrossing of the side branch, there's a waste on the side branch balloon. And the OCT tells us very clearly that while the main branch vessel is fully expanded, 92.7%, this feature called the rendered stent actually allows us to identify the side branch with intricate detail. And by turning on this 3D bifurcation mode, we can see where the problem is. The problem is that the strut, the wire has crossed through the proximal strut instead of the distal strut. And so this is problematic. You may ask yourself, does it really matter? A lot of us talk about this, that the wire has gone through the wrong strut, but is there a clinical benefit or is there a biological benefit? Well, let's take a look. On the left side, you see the pre-OCT where the wire has access to proximal strut, and the right side, there's rewiring under the distal strut. And let's take a look at what the OCTs look like between the two. The proximal cell strut following kissing balloon inflation is on top, and the distal strut is on the bottom. You can see that the orifice of the side branch is clearly identified by OCT. There are now no longer any struts crossing the orifice, and you have a nice circular carina. Particularly in bifurcations where the risk of restenosis is highest at the side branch, this is of major benefit. And in the end, not only is there a good angiographic result, but also evidence from intravascular imaging that you performed an optimal PCI. What about restenosis? This is another high-risk category with a hazard ratio of about 1.88. Now, angiographically, you can see that both of these lesions have the same phenotype. They appear to have an in-stent restenosis. However, the mechanism of restenosis is completely different. On the left side, this is an underexpanded stent, and on the right side, this is neointimal hyperplasia. There is no way to be able to determine this from angiography, and if I would put my hat on anything where intravascular imaging is an absolute must outside of the left main, it really is for in-stent restenosis and stent failure. And it turns out that this underexpansion is actually very common. In the first year following stenting, it's somewhere approximately 20% compared to 80% neointimal hyperplasia. And as time goes on, this continues to stay with similar numbers. So how can this guide you? Well, you can see that the OCT provides you automated measurements. You can see that the minimal stent area is 2.6, and there's minimal neointimal hyperplasia. So the treatment is guided by the OCT, which of course is simply a high pressure balloon. The last thing that you want to do in this situation is land another stent. But on this situation, it's completely the opposite. You still have a tight lumen stenosis. However, in this situation, you can see focal neointimal hyperplasia and identify predominant mechanism being tissue growth. And then rather than stenting the entire segment where we already know the risk of restenosis is high, we actually perform a very focused and targeted treatment specifically to the site of underexpansion. Ajay spoke to you earlier, or will speak to you next, about the impact of coronary artery calcification on long-term clinical outcomes, but I'd like to give you this important anecdote. In the Prospect 2 study, if we performed a procedure in the LAD and found in the non-culprit vessel calcified or lipidic plaque, the lipidic plaque cohort did significantly worse, suggesting that the calcified plaque provides a stable phenotype unlikely to lead to plaque rupture. However, as soon as we put in stents, this ratio goes backwards. All-cause death goes up, target lesion revascularization goes up, stent thrombosis goes up, and major adverse cardiovascular events go up. And put simply, there's only one explanation for why this is. And the explanation is that we are implanting the stents into severe calcification without appropriate vessel preparation, leading to stent underexpansion. How can OCT help? For the first time, we provide criteria by which you can determine which lesions may be treated by simple lesion preparation and which lesions need to be treated by a more complex lesion preparation, such as atherectomy. For example, this simple strategy, which divides a scoring system based on the following important parameters: a calcium angle of more than half of the artery, a maximum calcium thickness of 0.5 millimeter, calcium length of greater than 5 millimeters, leads to a score. And as you can see, the greater your score, the more likely you are to lead to underexpansion. How can you use this clinically? Well, if you identify that you have a score of 3 or 4, you have identified a lesion which will benefit from aggressive vessel preparation, including atherectomy. Here you can see a pre-PCI OCT where the vessel score is 4, and we perform atherectomy, which leads to a guttering of the atherectomy device, thinning of the plaque down to less than 0.5 millimeter. After the atherectomy reduces the thickness, we do a high pressure balloon inflation and fracture this calcium right in the middle of the segment, leading to optimal stent expansion that would otherwise not be able to be performed. The OCT can provide you the information of fractures throughout the entire vessel. Here's a vessel following rotablation which shows multiple calcium fractures, preempting that I know the vessel is now ready for stenting. And you can highlight these different types of plaque fractures or calcium fractures throughout the vessel, understanding the plaque morphology at each stage. We have an unpublished body of work which is going on currently, which is the ability to predict which calcified lesions can be fractured with a non-compliant balloon alone. And as we showed earlier, a calcium thickness of less than 0.5 millimeter and a calcium arc of greater than 221 millimeters are independent predictors of calcium fractures. What does that allow you to do? Why do you really want to know this? Well, the reason you want to know is because it allows you to optimally expand the stent. This is stent expansion that's performed following the calcium fracture. Here you can see perfect and stent expansion with a residual area stenosis in the distal half of a stent of 0%, and similarly complete expansion in the proximal half of the stent. What else can OCT tell you? Well, of course, angiography can determine the presence of calcium. It cannot evaluate arc thickness and length, which are independent predictors of stent expansion. Here, for example, you'd be able to identify this large calcified nodule on the angiogram, but you can see that the balloon result of this is simply displacement of the calcium away from the balloon and the leading to a large dissection. How can you perform your post-procedure assessment? It can be performed extremely rapidly to look for problems with the stent, such as tissue protrusion, major malapposition, edge dissections, and of course expansion. We can also use this in CTO PCI, particularly after the wire has crossed. This is a reverse cart case in the main LAD where we perform a post-PCI OCT and identify excellent stent expansion. But the OCT in this situation also tells us not to perform any more therapy, as there's a large aneurysmal segment in the subintimal space, and high pressure post-dilation in this position could be problematic, and as a result, the patient was discharged and brought back 3 months later for optimization of the stent. What about the newest and latest breaking? This is non-contrast solutions for OCT. I will leave you only that one of these images is with contrast and the other is with a non-contrast solution. So there is the future which has the ability to perform OCT without using contrast. This is a live case from Columbia Presbyterian Medical Center where there's a zero contrast PCI. Here you can see we're performing OCT without using any contrast, using a non-contrast solution with exquisite resolution, providing us all of the details that would normally be done with contrast. You can see that we're able to identify accurately both the distal reference measurements, the proximal reference measurements. Therefore, despite us using not a single drop of contrast, we are able to perform and plan for our PCI. The stent positioning can be performed using the angiographic co-registration with OCT. The stent can be placed precisely within 1 millimeter of standard deviation. Angiographic post-dilation is performed, and then following this, a post-PCI OCT, again without a single drop of contrast, shows that we can perform PCI that's optimal with full stent expansion and no edge complications without using a single drop of contrast. Here you can see that the distal stent is fully expanded, being more than 90%, and in the proximal half of the stent, again, perfect expansion. We described this in 2016. This was our first case. We've now performed over 100 PCIs without using any contrast, and hopefully be able to present this data to you very soon. I leave you with the idea and concept that we are not going to leave you with unanswered questions. Illumian 4 is a large multi-center randomized controlled trial which will randomize between 2,500 to 3,500 patients with exactly those characteristics that I described to you for the patients who are the most likely to benefit from intravascular imaging. I think we all agree that stenting a simple right coronary artery lesion with a 4.0 stent is unlikely to need intravascular imaging, certainly for the cost of the catheter that it is in India. But now we're talking about patients who likely have a significant benefit from intravascular imaging, and there's much more of a stake. As you can see, we're including only complex and high-risk patients, and what will perform OCT using a very specific protocolized algorithm or randomized to angiography and standard of care. Critically, for the first time ever, we will have a clinical endpoint which includes 1 to 2 year rates of target vessel failure, as well as the post-PCI minimal stent area. And I leave you with this last slide, which shows you that all of the questions that you have as to who is the most likely to benefit from intravascular imaging, we are performing this trial to answer these questions to provide the optimal treatment for our patients. Thank you very much.